This 2025 Best Abstract presentation describes how needle design may cause infection and impair cancer diagnostics in prostate biopsy, as well as introduce the Forsvall needle to address the problem. We think this is the most logical way to address both these major problems in prostate cancer diagnostics today. My name is Andreas Forsvall. I'm a Swedish urologist working 50% in the clinic and 50% in R&D, combined at Lund University and Saga Surgical. Saga Surgical is a company aiming to make our research available to patients, and my company involvement for Saga Surgical is also my disclosure for this talk. This is not a one-man show. Here is part of the Lund Saga multidisciplinary study group working to make needles safer and better. First, we need to understand how a TrueCut biopsy needle works and why it's important. It's a two-part needle. The needle is aimed at the target and fired. This firing takes about 1/50th of a second. During this 1/50th of a second, the inner needle is fired, tissue fills the chamber, and the outer needle closes. The biopsy is secured. This is a vital instrument. Cancer diagnostics is based on the tissue collected by the needle. It hence connects all the diagnostic workup with all the treatment options. It's, however, not a new instrument. This is the 1969 patent. For reference, it's a 1969 moon landing and a 1969 Volvo. Looking at the mechanism of action is the exact same as described in 1969. The needle tip is also a blueprint of 1969. Recall that this is now 56 years ago, way ahead of the antibiotic resistance problem of today. Targeting and infection prevention was not an issue. Well, times have changed. Infection is now a major problem, affecting 2 to 3% of patients in transrectal biopsy. MRI target biopsies are golden standard in most parts of the world. We know infections are due to bacteria being introduced in sterile tissue at the time of biopsy. We know that it's the needle that transports these bacteria that causes infection. We currently address this fact with antibiotics to kill off transported bacteria in the prostate. We may use augmented prophylaxis, where we first take a rectal culture to guide the choice of antibiotics. Povidone iodine to reduce the bacterial load in the rectum, and transperineal biopsy to void the rectum. But we do not currently address the root cause, the bacterial transfer. This is what a TrueCut needle looks like after passing the rectal wall. What you see here is tissue and fecal matter trapped between the TrueCut needle parts. When moved in tissue, bacteria are collected around the inner needle part. The outer needle part acts as a circular knife, cutting tissue, but also traps bacteria inside the needle. We tried to design around it. Our solution is the Forsvall biopsy needle. We enlarged the tip of the needle so it aligns with the rest of the needle, creating a completely smooth needle, eliminating the area where bacteria are trapped in the TrueCut needle. Technically, this moves a forward-facing large opening to a side-facing force-closed connection between needle parts. The result? A 96% reduction in bacterial transfer. We found this in a randomized study where we punctured colons after colon surgery, simulating transrectal prostate biopsy as closely as possible. 80 cultures from needles were blinded and compared. Now, we just don't take a prostate biopsy anymore. We specifically aim at a target identified by MRI. This target is then heterogenic, often consists of a combination of different aggressiveness of the cancer, different Gleason grades. Current 1969 needles were not designed for this. They tend to deviate, sometimes heavily. They do this in 2 steps. On the way to target, this is known to all urologists and depending on tissue density and distance traveled. Sometimes it looks straight, sometimes the needle actually moves the tissue, still a deviation of target. And then when taking a biopsy, remember it takes 1/50th of a second and the ultrasound is 50 Hz. This is too fast to notice. You can see the deviation of the inner part of the needle on this cutout of a melon. We believe the total deviation is hence a lot larger than urologists currently think. We evaluated why the needle deviates and try to improve it. Main reasons for deviation are the surfaces here, and tolerance between the needle parts, also causing infection. The Forsvall needle is a closed needle. The needle parts stabilize each other using design and a specially designed biopsy gun. This in combination with a special grinding of the tip makes the needle travel straighter. We did a lot of proof of concepts in gel. This one is made in my kitchen by adding gel to half a juice package. First we see the movements of the TrueCut needle. This is the first deviation seen by urologists. Please note the second, normally not visible deviation by the needle tip. Here slow down to show it. The stiff outer needle tube straightens it so it looks as the needle have moved straight. And this is the Forsvall needle in the same gel. We did a study based on these findings, simulating a distal target in the prostate. In transrectal biopsy, we are bad at sampling anterior tumors. In transperineal biopsy, we're bad at sampling basal tumors. The further away from the needle point of entry, the worse we seem to do. We aim to simulate this situation. This ballistic gel study is, to our knowledge, the first to look at what we actually collect in the tissue chamber, simulating both deviation on the way to target and at the time of biopsy. Remember, the material in the biopsy needle is what we use to diagnose prostate cancer and guide cancer treatments. We simulated 15 transperineal and 10 transrectal biopsies, aiming at an 8 mm Pyrites 4 lesion, the central part of the target. Here TP stands for simulated transperineal biopsy and TR transrectal biopsy. The TrueCut needle deviated 6 and 4.7 mm on average in TP and TR biopsies. The Forsvall needle deviated on average 2.2 and 2.3 mm. Both needles collected adequate amount of total simulated tissue, 84 to 89% of chamber length. The primary endpoint was, however, the amount of target collected by the biopsy needle. The TrueCut needle failed to collect any target in the 15 TP biopsies and only hit the target once in TR. The theoretical maximum was 8 mm, and the Forsvall needle collected on average 4.8 mm in TP and 4 mm in TR. Hence, the 1969 TrueCut needle only collected from the target in 1 of 25 biopsies. The 2025 Forsvall collected in all 25 biopsies. However, a new needle is useless if it reduces bacterial transfer and moves more accurately in tissue, but does not collect sufficient in vivo biopsies. Hence, we did an RCT of 249 biopsies in 20 patients. Biopsy length and patient experience was non-inferior. To conclude, we hope to make prostate biopsy safer and better. It's about time for a 2025 take on the 1969 needle. In vivo and in vitro studies, the Forsvall needle reduced bacterial transfer by 96% and significantly improved on-target biopsy in both TP and TR. We are very much looking forward to future clinical data on these physical changes to the biopsy needle. So think about it. All scientific data we have is from a needle that deviates off target and collects and transports bacteria into the prostate. This goes for infection rates in both transrectal and transperineal biopsy, comparison of both TR and TP, and also cancer detection rates in both. So if you ever had patients with a biopsy infection or aimed for a large target and only got a few millimeters of cancer in return, this may be the reason. The 2025 Forsvall needle is recently FDA cleared, closing a 10-year R&D circle. It's available for clinical use in the USA, and we can't wait to get user feedback and real-world data. We also plan for 2 RCTs looking at cancer detection and infection. Here are my contacts. If you have questions, want to try the needle, participate in trials, please contact me. Thank you very much for your attention.